Welcome. I'm Michelle Cowles, Director of Business Development with Rogers Behavioral Health, and I am your moderator for today's webinar, the first in a two-part series on treating co-occurring mental health and addiction. Next week, my colleague Christine will moderate the second webinar. Joining me today are Dr. Gabrielle Jones, Clinical Supervisor at Rogers San Francisco East Bay Clinic in Walnut Creek, and Dr. Sean LeNoue, an addiction psychiatrist based at Rogers Nashville location, and Dr. Michelle Maloney, the Executive Director of Addiction Services at Rogers. Before we get started, I wanted to give a quick overview of the format. The webinar is scheduled for 90 minutes. There is no need to check in. In order to receive CE credits, you must be logged into the webinar for the entire program. We are recording the webinar and will publish it on our website, along with a PDF of the slides for you to rewatch at your convenience. However, please note that CE credits will not be awarded for simply watching the recording. Doctors Jones, LeNoue, and Maloney will give a 75-minute presentation. Following their presentation, I will facilitate the Q&A session. If you would like to ask our presenters a question during the presentation, please use the Q&A button, not the chat button, to send me a message. At the bottom of your screen, you simply click on the Q&A button on the Zoom taskbar. I will review the questions submitted and the presenters will address them during the Q&A portion of the webinar. Now I'll turn it over to our presenters.
Thank you, Michelle. Hello, everyone. My name is Dr. Gabrielle Jones, and I'm going to start us off. Starting with our disclosures, this statement just indicates that we have all declared that we do not, nor do our family members, have a relationship in any amount occurring in the last 12 months with a commercial interest whose products or services are discussed in the presentation. Myself, Dr. LeNoue, and Dr. Maloney have each declared that we do not have any relevant non-financial relationships. Additionally, all planners involved do not have any financial relationships. Our learning objectives for today's webinar: upon completion of the instructional program, participants should be able to explain 3 factors that need to be considered when conducting telehealth with someone who has a substance use disorder, identify 2 increased risks associated specifically with conducting telehealth with substance use disordered populations as a result of COVID-19, and identify 2 reasons for conducting a risk assessment with a substance use disordered patient via telehealth. And in this webinar, what we'll cover are an overview of the challenges in treating mental health and addiction disorders during COVID-19. That includes substance use disorder stigma, virtual intake differences and limitations, as well as home environment considerations, considerations for conducting telehealth treatment. So we'll discuss some evidence-based treatment options that may be helpful for you to use, as well as logistics of providing care in a virtual world. Challenges treating mental health and addiction disorders during COVID-19, in which we will discuss isolation and risk for overdose, engaging tech-savvy youth and drug screening. And finally, we will discuss assessment of patient needs and risk factors, which includes talking about vulnerable populations, their need for extra support now, increased access to substances, which is an issue that is occurring as a result of COVID, as well as development of new or worsening mental health and addiction related issues due to stressors associated with COVID-19. So starting off, thank you. Yeah, so starting off, we will go over an overview of challenges in treating mental health and addiction disorders during COVID-19 And I just want to say to everyone watching that these are general stigmas, these are general limitations and general considerations. So the intention behind this next set of information, or these next pieces of information, is to be very mindful that this may not apply to everyone, but it is general and it applies to many who have experienced substance use disorder in conjunction with being in the shelter in place and with COVID. So starting with substance use disorder stigma, stigmatizing factors to consider. This is really important, not just because of the fact that we're in COVID-19, but also because these are stigmas that are continuing to manifest themselves and become more salient as a result of COVID-19. That's not to say that these stigmas have not already been in place, but that they're more present as a result of the shelter in place around the country and COVID-19. So we have discrimination, ethnic and racial minority discrimination in treatment. The current state of our country, there have been a lot of discussions and protests around racial discrimination and social justice, and there are a disproportionate amount of African Americans who have contracted COVID and have not been able to receive treatment, in addition to having a substance use disorder, in addition to dealing with the trauma of the killings and deaths of African Americans across the country. And because of these things, a lot of times, specifically in the African American population, in treatment, what that translates to is consequences instead of providing support. So you may experience a patient who has a substance use disorder and they come in and they're very resistant to what you suggest. They're very resistant to following treatment protocol, or they seem a little bit uncomfortable with the treatment recommendations. And instead of meeting them where they're at, oftentimes what research has shown is that people of color with substance use disorders are punished. So they're either discharged from treatment, or they're labeled as non-compliant, or they are seen as inappropriate for any particular level of care. And it's really important to recognize the institutionalized racism that occurs when we're dealing with substance use disorder, and really take into account those other factors that I mentioned and provide support for those patients who are coming to you with a substance use disorder and are seeking treatment. And we'll talk a little bit more later on about how to intervene at different levels depending on where patients are, but just something to consider when you have a patient who may be resistant to treatment initially, who's a person of color, or who may not necessarily align with the initial treatment recommendations. Specifically related to telehealth, it's much more difficult to translate empathy across a technology platform. And unfortunately, that causes issues with regard to treatment success among African American populations. Research has shown that empathy is a mediating factor for treatment success among African American populations. And so that is something, and that's something that is important for all groups who are dealing with a substance use disorder, to feel connected, to feel supported. And so it's really important to identify, as a clinician yourself, what can I do to translate that empathy through technology, whether that is having a conversation before jumping into your intake with your patient or your client, whether that looks like asking questions about how they're doing in general, and just really working on that, building that rapport. And I know I'm talking specifically about the African American population, but that's not limited. That's just where the most research is with regard to empathy and technology. In our next presentation next week, I will go in much more detail about various ethnic and cultural backgrounds and some of the things that we need to consider in more depth. There are less resources to engage in treatment for these populations. A lot of times they either don't have a computer, and this is for people who are in a lower socioeconomic status, or people who are of a lesser capacity. They may not have internet access, they may not have video capabilities. And so, again, instead of consequences, we want to make sure that we're providing support, whether that looks like seeking support from our organizations, if you're part of an organization, or otherwise. In some cases, you're dealing with people who have substance use disorders, but they are essential workers. And those can be issues around when to schedule appointments, and when to attend meetings, and the inability to miss work. So a lot of times, depending on the level of care that you work in, it is important for a patient to be available for their groups, or their appointment with their psychiatrist, or their individual therapy appointment. But if they're financially unable to miss work and they can't make those appointments, but they need to pay for those appointments, they're sort of in a catch-22. And this is, again, more specifically related to people of color, marginalized populations, populations that are discriminated against. And these are stigmatizing factors that a lot of clinicians and providers maybe don't take into account up front when they're working with this group of people. Further, when we're talking about substance use disorder stigma, we can look at sexual or gender minorities and their comorbidity of use as a stigmatizing factor to consider, because this population is often also discriminated against, and that research shows that their substance use is increased based on the discrimination that they experience, specifically sexual gender minority patients. So if you have patients who fall in this category, a lot of times, one of the things to consider as you're assessing and as you're working with them is the discrimination contributing to their substance use? So depending on whatever your theoretical orientation may be, research has shown that this is a mitigating factor for increased substance use. So that's something to keep in mind. Programs often don't include comprehensive treatment to meet the needs of this population. So treatment may address substance use specifically, but ignore those other discriminatory concerns that are specifically related to the LGBTQI community. And as a result of that, we're missing a whole piece of our treatment interventions. So it's really important, telehealth specifically, to recognize that a patient may exhibit more difficulty reporting their gender identity to you, especially if they're a sexual or gender minority and of a cultural, racial, or ethnic minority as well, and that intersectionality of their identity may be difficult for them to engage with you via telehealth, as I had mentioned, because of that lack of empathy through that technology platform. And depending on where you are in the country, this question is not primary at intakes. So I'm located in California, and the question of your sexual orientation or gender identity is very present in intakes in the mental health field, but that may not be the case in a different state. So you'll want to really pay attention to focusing in that area when you are doing assessment, when you are meeting patients for the first time or interacting with the clients for the first time. Make sure that you are identifying and paying attention to these different forms of identity. Oftentimes, stigma will also, specifically for vulnerable populations and marginalized populations, stigma will lead to misdiagnosing. So misdiagnosis may be due to the clinician's level of comfort with treating substance use disorders. If you are a provider and you don't treat substance use disorders on a regular basis and a client or a patient mentions to you that they use substances on a regular basis, then your diagnosis may be primarily focused in their depression and not necessarily focused on their substance use. That may also play a role in what your theoretical orientation is, how you conceptualize that patient. In some cases, the perception of what is called a moral defect is what causes a misdiagnosis. So essentially, that's just saying that some providers may think that substance use can be stopped, or that substance use isn't necessarily something that is treatable, instead of it being a medical diagnosis, and that may cause misdiagnosing. And because of that, we run into ineffective treatment interventions because we're treating one thing but not the other. And unfortunately, that is not how substance use disorder treatment is conceptualized. You want to treat the whole person, as many aspects of them as you can. And research shows that that provides a higher recovery outcome than just treating one mental health illness and then treating another one later. And sometimes those ineffective treatment interventions come because of a lack of adequate assessment, like I had mentioned previously. Specifically related to telehealth, clinicians may only have the patient report to rely on initial clinical information. And what that tends to look like when we're doing telehealth is you're meeting with a patient and you're talking with a patient and you're talking via telehealth. Whereas if a patient were to come into the clinic, you may be able to provide them a drug test. You may be able to do some brief screeners. You may be able to, depending on the environment that you work in, you may be able to have them connect with a nurse. But through telehealth, it's much more difficult to do that. And if you're dealing with marginalized populations or lower SES populations who are essential workers or who don't have access or means, it may be even more difficult for them to provide you with the information that you need to get an adequate assessment because of their lack of historical knowledge. So seeking treatment is also a stigmatizing factor to consider when we're talking about substance use disorder, and it's even more difficult with telehealth. So that's not to say that it's not something that occurs without telehealth. It happens in both instances, because of general substance use disorder stigma, and this goes for everyone. So oftentimes patients are less likely to seek treatment as a result of the stigma that this is a moral defect and I should be able to handle it, or the inappropriate language that's used around substance use disorder, like junkie, or I'm, just an addict and there's nothing that can be resolved in that capacity. So there's this low self-esteem that tends to come with the lack of seeking treatment because of the stigma that has been placed around substance use disorder in general. And I think one of the things for everyone to consider is just the language that we use as providers, because that really makes a difference in how someone sees substance use disorder. We try to use person first language. So a person with a substance use disorder instead of an addict or someone who's an alcoholic or a substance user even. So shifting your language can help reduce that stigma in general, with or without telehealth, but being very mindful and intentional about the language that you use when you are doing telehealth. And also, patients are less likely to report substance use in general due to stigma. So someone may come into your office based on anxiety and wanting to work on anxiety. And if you don't do an assessment about substance use, if you didn't ask, I might not tell. And so it's really important, because that is a factor that is birthed specifically out of the stigma. So additionally, stigma leads to poor health outcomes in general. Research has shown that if you have a delay in receiving treatment, that may increase the likelihood that you'll have to go to the hospital, which then increases serious medical conditions, which we'll talk about more at our next webinar, but just briefly touching on the fact that if someone does not seek treatment for their alcohol use disorder and they end up in the hospital because of liver failure, liver damage, or they continue to go to the hospital based on with alcohol withdrawal symptoms because they can't manage those, that increases their hospital visits, but it's telling them something that there's something going on with their body physically that needs to be treated, but they're not seeking or obtaining all of the treatment that they need in order to get beyond the substance use disorder. And we'll talk about ways to integrate treatment here in a few minutes. So some of the general takeaways for virtual intakes versus traditional intakes and the differences and limitations include, like I had mentioned before, you have a multidisciplinary team available in person, generally, depending on the environment that you're in. You have a nurse, you have your psychiatrist, you have your psychologist, you have a therapist, you may have a dietitian, depending on where you work. And so that provides a lot of information. The client or patient may present differently in different settings with different people, and all of that is valuable clinical information that you may not get via telehealth. It allows for flexibility if assessments take longer, so you can, make a brief phone call and someone can tell your next client or patient, hey, Dr. So-and-so is running late, or hey, your therapist is running late, whereas that may not be the case with telehealth. Traditional intakes provide real-time feedback and results if drug tests are administered in most cases, and it's beneficial for rapid treatment planning and intervention as needed. Dr. LeNoue will talk more about overdosing and things like that, but when you're in a traditional intake process, when you're in a clinic, a lot of times with substance use disorder specifically, it's critical because you're able to get the needs of that patient met pretty quickly, as opposed to that patient being at their house and you being somewhere else, and then you having to make a phone call depending on the situation to get them to safety. Varying forms of assessment are available. You have drug testing, and you can enact your protocol for intoxicated patients. If a patient were to come into the clinic intoxicated or come into your office intoxicated, generally have a protocol for that you can enact, which is a bit different with virtual intakes. Specifically with virtual intakes, that things to consider, there are specific risks increased due to telehealth. There's a time delay for providing patient detoxification medications if a patient needs a detox, like I mentioned. There's less accuracy in assessing if patient is currently intoxicated. That's a very tricky thing to diagnose or identify if a patient has a long history of substance use disorder and functions within their substance use disorder. You may not be able to see it as readily in a telehealth session as you would in person. So it's really important to pay attention to their eyes when you're doing a telehealth session. Pay attention to if they're fidgety when you're doing a telehealth session. And if they do endorse substance use, really kind of go in more depth with your questioning to see if there's a need for you to do something about them if they are intoxicated. So questions as simple as, when's the last time that you used your substance? When's the last time you had been sober, or whatever the case may be. As a result, this increases the risk of patient overdose, unfortunately, because with telehealth, we may not be able to see, like I said, rapidly what the patient is doing and if they are in fact intoxicated. So it's really important to do in-depth assessment when you're working with patients who have endorsed substance use disorder, or if you are a provider who treats substance use disorder, to make sure that via telehealth, you're going even further in your screening and your questions than you would in person. It's also more challenging to obtain a baseline UTOX screen. So that's a drug test. And the reason for that is if you're doing a telehealth virtual session and that's your first time meeting with a patient, you have to tell the patient, okay, go to the store, get a drug test, and then tell me what the results are. Or you have them go to a clinic and that gives them time to potentially flush their system. So you have to be mindful about that too, because you may not have an accurate or a true baseline. Patient quality of care tends to be diminished because of all of the things that I've mentioned, but in addition, because of time constraints due to other scheduled virtual appointments. I don't know about any of you, but I know that my schedule is stacked back to back, and it's very difficult to move from appointment to appointment with some breathing time or even time to go to the restroom. So the time constraints are an actual factor that you want to take into consideration. And a way to mitigate that, I know it may sound trivial, but just being mindful of your schedule and putting some space in between to go to the bathroom or to get a snack if you need one. Less ability to ask someone to let your patient know if you're running behind. A lot of times in telehealth, it is more difficult to access a receptionist or someone else to contact your patient or your client via telehealth to tell them that you're running late. So it may even be something as simple as incorporating that caveat in your consent forms. I may be 5 or 10 minutes late if I'm running from another meeting to your meeting. Please be patient and I'll be with you shortly, so that the patients are ready and prepared and don't get agitated. That's just good client care that a lot of times we take for granted while doing in-person work. So transitioning to home environment considerations, some things to consider are the family dynamics. Is there anyone in the home with patient? This may raise some safety issues if the person that you're working with is intoxicated or if they do use extensively. This can also cause issues with regard to confidentiality. If there are a lot of people in the home and your patient or client doesn't have a private space to go to, that's something to keep in mind, because that may add to the fact that they're less honest about what they're talking about to you. So ways to mitigate that are for them to put in headphones. You can ask them yes or no questions to adjust your intake in ways that are more productive and helpful if they don't have a space to kind of talk freely. And it also builds rapport with them. Some other things to consider: do family members in the home use substances? This may increase their risk of relapse, because if that's what's going on at the house and they don't have any supports, then what's really going to stop them when you're not with them on video? So you really have to take that into consideration. And like I said, we'll talk about evidence-based practices that you can use. Are there children in the home? If there are children in the home, that's really important to consider as well, because there may be further risk factors that you need to consider. Do you need to file a CPS report if the parent is not able to care for the child? Is there neglect going on? So telehealth is great for convenience, but it also opens up a whole host of questions that you may not have considered regularly or readily, while you were working in clinic. So just things to think about. And then, does the patient have any support in their home environment? Support is a huge, well-researched aspect of substance use treatment, and how important it is to obtain connection and have sober supports. So it's good to know whether your patient or your client has that in their home. Substances is a home environment consideration to think about as well. because it may be more difficult for patients to remove all substances from the home if they have a family member who's using as well. It may be difficult for them to remove all substances in the home if they're really struggling and they don't have any support. So you may be encouraging them to throw away their alcohol or get rid of their cannabis, and there's no one holding them accountable except for you once a week, or depending on whichever program or department you're in, it may be a couple times a week, but yet and still majority of their time is not with you, so it makes it difficult to remove those substances.
You know, Dr. Jones, you mentioned the substances, and, you know, in this midst of COVID, there certainly has been an increased availability of hand sanitizer. A lot of the distilleries stopped making alcohol and started making hand sanitizer. So many of our patients are finding hand sanitizer in what looks like vodka bottles. And just the smell of hand sanitizer on their hands has been creating a lot of triggers. And we've been finding a lot of patients have been relapsing on hand sanitizer.
Correct, correct. Thank you, Dr. Maloney. All right, so transitioning into considerations for conducting telehealth treatment. Now we're going to go into evidence-based treatment options and some of the logistics for providing care in a virtual world. So this is broken up into evidence-based treatment options for adults and evidence-based treatment options for adolescents. There are a lot of treatment options that you can shift and adjust depending on what type of person you're working with, but that's kind of how this next section is laid out. So we have pharmacotherapy, which would be an evidence-based treatment like CBT and medication management, or nicotine replacement therapy. So you're essentially working with the behavioral piece and the pharmacological piece of the patient's substance use disorder. And this opens it up for you if you're working on a patient or a client with depression or anxiety or PTSD or so on and so forth. Adding a supplement of medication management is really helpful. Cognitive behavioral therapy. This is a behavioral intervention that focuses on the interaction between thoughts, behaviors, and feelings, addressing maladaptive behaviors to promote adaptive behaviors. And the focus is really on developing coping strategies. Now, this is important specifically for telehealth. A lot of people are familiar with CBT already, but with telehealth, one of the main benefits that CBT offers is that it provides coping strategies when you're not working with your patient. So there may be providers who prefer psychoanalytic, psychodynamic, or differing forms of talk therapy. But when we're in a virtual world and we're doing telehealth in the age of COVID-19, it's critical that with substance use disorder, we're giving our patients and clients something to do outside of the treatment time that they have. So giving them coping strategies, helping them understand and better conceptualize their own substance use disorder or addiction. Motivational enhancement therapy, which also incorporates motivational interviewing, is more supplemental. It's a more supplemental intervention, and it is used more frequently with patients who are not motivated to stop, or their level of change is pre-contemplative or contemplative. And in those cases, it's really important to supplement it with something like a CBT model, because motivational enhancement therapy is not necessarily intended to promote behavior change, but it is more intended to increase awareness and also raise concern or raise consciousness about a person's substance use and whether they believe it's a problem or not. So really getting some buy-in on that regard. Then we have contingency management. This is really difficult with COVID-19, but it is still an intervention that can be used. We just have to get a little more creative about it. So contingency management is essentially an evidence-based treatment option that allows for rewards. It's a rewards-based system. So it encourages behavior and rewards based on that behavior. So it may be helpful for you in trying to build rapport with patients to utilize contingency management and encouraging them to identify different self-care practices that may allow them to be more intentional with their time while shifting their focus from use to an activity. So if they haven't really given themselves a facial or painted their nails or their toes or given themselves a pedicure, that may be something that you can utilize, or trying a new in-home workout routine, or trying to cook a dish that they like that they haven't made before. I know that with some of my patients, what I've done in the past is if you have boxed goods, or if you have jarred goods, or if you have canned goods, or even frozen goods, a lot of times those items have recipes on the back. And it can be really fun to just try that recipe out and see how it goes, because you've clearly already bought the item. And so the intention is to branch out and cook something that is with the item that you already purchased. So that may be something that is helpful and can promote and facilitate self-care with patients. But again, contingency management can be a little more tricky and a little more difficult because it is really rewards-based. And when you're in a shelter-in-place order, going out is not necessarily an option, and we don't want to promote that for the safety and health of our patients and clients. Then there's the community reinforcement approach. This can be more beneficial during COVID to engage other members of the home. So this treatment is really intended to utilize external supports, improve family relations, and utilize the community. So whether that be your neighborhood or your compound, if that's what they live in, or their apartment complex, or the family system within the system. So siblings, aunts, uncles, people who are naturally around your patient or your client for more than the amount of time that they are in treatment program, utilizing them to help support your patient or client. It is skill-based, and actually they have a computer-based version called the Therapeutic Education System that can serve as a community reinforcement approach. So this one is really beneficial to look into if you haven't already, as far as a treatment intervention for substance use disorders in adults, because they've already developed a computer-based version, and you can use that in conjunction with your time with your patients. There's also the matrix model. Now, before I go into this, I do want to highlight that this model has been debunked, but there are very helpful aspects of this model that you can utilize. So similar to pulling motivational interviewing in with any other treatment intervention, or utilizing CPT as a supplement to other treatment interventions, these are specific skills that you can incorporate, not specifically the model, but skills. And I wanted to make sure that I highlighted these because there are some things that are helpful. So it already combines various interventions, utilizing peer support groups, utilizing worksheets, utilizing individual sessions. There are various handouts that can be used, and the emphasis is on the relationship between the client and the therapist. And the therapist kind of acts more as a coach and encourages the patient to assist in building self-esteem and self-worth. Now, I want to go back to my earlier slide where I discussed that empathy really plays a role in telehealth more saliently with patients who have substance use disorder. So this intervention, the encouragement of the relationship between the patient and client, is really what I want people to take away from this slide, because that is a part of telehealth that tends to be lacking that we can do more with. And then we have evidence-based treatment options for adolescents. So again, cognitive behavioral therapy, it's evidence-based, it's a behavioral treatment. The emphasis is based on skill building again and utilizing coping strategies other than substance use. And it continues to illuminate the relationship between thoughts, feelings, and behaviors. When we're dealing with adolescents, it is critical that we are concrete and that we give them skills and build skills. We can't say, stop smoking weed, and then, okay, so what am I supposed to do? I can't hang out with my friends. I can't go here. I can't do that. So cognitive behavioral therapy really allows you to create a toolbox for teens to have skills and have coping strategies that are alternative to substance use. And then we have the community reinforcement approach and family training, which is CRAFT, which is the adolescent version of the community reinforcement approach. And the emphasis is, again, on problem solving within the family unit, within their system, active coping strategies, building communication skills, and specifically for adolescents, pro-social engagement. So again, in COVID, this may be a little more challenging and you have to get a little more creative, but building vocational skills and encouraging family interaction is generally helpful. So encouraging a game night with family or sharing your screen with your patient or your client to apply for a job. So you can still facilitate or help promote that pro-social engagement in a way that's productive without them necessarily going out and doing something. Then we have functional family therapy for adolescents. This is generally used more with adolescents who have been involved in the criminal justice system or who have a history of conflict in terms of their behaviors. And this is intended to engage family members in therapy sessions to increase support. It utilizes contingency management, which I discussed a little bit earlier, and it facilitates motivation for change and utilizing motivational interviewing. This one is specifically helpful for adolescents who have family members who may use as well or have a substance use disorder in the household, because you're essentially treating the entire family. You're not just treating one person. Functional family therapy is generally more effective for families of color as well, because it facilitates that community, that family connectedness instead of the individuality. Same with multisystemic therapy. Multisystemic therapy utilizes natural environments to address substance use in teens. So it encourages teens to utilize their healthy environments for support, whether that be school, church, someone safe at home, their neighborhood, their peers. And so what this may look like in the age of telehealth is encouraging your teen patient or client to set up a video call with their youth pastor or set up a Zoom meetup with their friends. So that way they are receiving support and they're being encouraged by those people who they already trust and feel safe with. And in the event that you struggle more with connecting with them with the empathetic piece via telehealth, you're able to facilitate that with their natural environments. So some of the logistics of providing care in a virtual world, the abstinence approach tends to be a little more difficulty for tracking. So depending on the substance a patient is using, it may be out of their system by the time you complete a drug test, which I've mentioned. And you want to make efforts to utilize random in-home testing for most accurate information as a solution to that. There are ways to make sure that the patient or the client has whatever you've ordered for them at their house. And if you meet with them one day, you say, okay, go do this drug test and then come back to the video. And Dr. LeNoue will talk more about drug testing in detail. Reduced motivation for abstinence. Reduction in the ability to engage in out-of-home activities may increase difficulty of remaining abstinence during programs. So you have to think about the fact that they're, in home and they don't have anywhere to go or anything to do, and they may feel isolated. And so their motivation may decrease as a result of that. A way to challenge that, combat that, is to work with the patient to create a list of safe activities to engage in that may still be in the home, as well as discussing having them find an accountability partner or have someone in the house to assist them with remaining abstinent. And then there's the harm reduction approach. So some of the logistics are providing accurate information regarding the amount consumed may be more difficult to obtain, similarly to obtaining adequate drug tests. So you may, with a harm reduction approach, shift your focus to the family dynamics or the environment that they're in or their motivation for use. So this approach emphasizes change talk more than abstinence. So your focus kind of shifts when you're doing harm reduction in telehealth. With telehealth specifically, you'll want to utilize worksheets and have the patient track their use. And in some cases, this can be used as its own intervention because they're home and they're tracking more frequently. So they see how much they thought they were using versus how much they're really using.
Thanks, Dr. Jones. One of the things I would recommend as we look at not only the evidence-based treatment options that Dr. Jones has reviewed, but also your approach is to really think about that evidence-based practice, that combination of research, your clinical judgment, but also the patient's values, the patient's cultures. So as Dr. LeNoue begins to talk about the pharmacotherapy, we think about, the use of medications, and if the patient's insurance, let's say, won't cover that and they won't continue, that may not be an evidence-based practice for that particular patient. So as you think about those different elements that, intersect in determining the best approach for that individual patient.
Absolutely. Thank you, Dr. Maloney.
All right. Well, thank you so much, Dr. Jones and Dr. Maloney here. So I'm Dr. Sean LeNoue, and I'm going to be chatting with you all here for a bit, thinking about the challenges of treating mental health and addiction disorders during COVID. And, I think to start, I just wanted to say, harking back to the comment just made about that this treatment approach is multifaceted, and that individuals struggling with substance use disorders typically have a variety of different complexities that can come into play. But I think that is an opportunity. And so when we, encounter challenges, and we could use, individuals struggling with substance use, right? There are a multitude of opportunities that we then have to be able to intervene, to provide education, to provide support, and to help an individual to engage and really take ownership. Because in many ways, when someone is struggling with a substance use disorder, there many times can be an utter or at least partial, loss of control. And so helping that individual to regain control, especially during these uncertain times in COVID, I think it can be really powerful, can resonate, and can really help to increase rapport and buy-in when we think about recovery and change. So without further ado, we'll get started here. So in this section, we're going to be talking about isolation and risk for overdose in particular. We'll also talk about the physiologic effects of stress on substance use, and certainly the effect that mental health issues have on substance use. And then we'll think about the cost of substance use overall, a brief overview, and thinking about as well engaging youth, right? So substance use disorders often, have precursors or begin in part in some way during an individual's adolescence or youth. And so I'm a child psychiatrist in addition to an addiction psychiatrist. And so really working with adolescents, young adults is certainly an area that is really important to me. And it's, again, an opportunity to help to create hopefully lasting change. And while we'll talk here in this section about what we can do to provide treatment for individuals who are, maybe sadly in the throes of their struggle with substance use. I would also just say that when we think about our youth, that really one of the best treatments that we have to offer overall is going to be prevention. And so we'll think about that. And then I'll also highlight some options and opportunities again for drug screening. So we'll move to the next slide here, please. So just highlighting here that isolation really does create in many ways sort of this perfect storm for substance use, possible relapse, and even sadly overdose. And while this is by no means all inclusive, these are sort of a few key issues that come into play, especially during this time of COVID, where social distancing, stay-at-home orders are in play, and we know that that's shifting even sometimes day to day, the guidance and recommendations. But overall, we as a society are maybe not as connected physically in person as we typically are. And so when we think about that isolation, that can create in turn less structure and therefore less accountability. Also, we'll talk a bit about this too in the age of technology, the internet, and just ease of access, that really substances have been in many ways, even prior to COVID, easier to acquire and use. And so we'll think about that as a key issue here. We also, as Dr. Jones already mentioned, in thinking about doing an intake and providing treatment and care over telehealth, that there are challenges with being able to identify substance use, intoxication, withdrawal. I think certainly that is something that has always been a challenge. That's not necessarily unique in some ways to telehealth care during COVID, but certainly, that virtual medium does provide a bit of challenge when it comes to being able to as effectively identify, is someone just a little bit tired today, or are they kind of nodding out? We don't have our other senses in many ways to be able to, say if I was sitting in the room with someone, like they smell of alcohol, or maybe some other signs that would maybe serve as hints or clues that something else is going on. I mean, clearly, even on screen, when someone is, highly intoxicated or clearly exhibiting significant withdrawals, even not so significant signs or symptoms, it can be obvious there as well, but there are new challenges. So, and then overall, because of these issues, we think about there being this increased risk overall for relapse and overdose. So, where we typically, our approach is that we really see this medium as an opportunity to engage, and it is an opportunity to be able to meet people in different places and times in their lives that, frankly, were not always possible prior to COVID. And so while clearly we don't ever, want a pandemic or any sort of challenge like the one that we're facing to happen, with it though can come opportunity. And so that's, I think, what we want to continue to highlight. So we'll move on and think about, in addition to isolation and that risk for relapse and overdose, we'll think about kind of the why. Some of it is obvious, some of it maybe not as much. For the experienced professional, we know that times of decreased use or abstinence are always the goal. But I think that context is key. And by that, I mean, we'll think about individuals, if anyone here has worked with someone who's maybe been incarcerated, they've gone to jail or gone to prison, where certainly we know substances are still available, but maybe not, as much, or maybe an individual has access to a lot of, drugs or substances, but maybe they don't use as much as they previously had done. So during those times, the point here is that when use goes down or abstinence occurs, that's always a good thing. But then we have to think about the stressors in the context of the environment and situation, because we know that times we'll use opioids as an example, that when someone has achieved and maintained abstinence, and then if they relapse, that is a time in particular when they are at heightened risk, even more than usual, for the risk of overdose, because during that time of reduced use or total abstinence, they lose their tolerance for the substance. which certainly is a good thing overall, but in the context of then resuming use, especially when they resume at elevated levels, quantities of use that they had maybe previously been accustomed to doing, that, that dose that before may have only provided like, a mild sort of buzz could potentially be lethal for them. So just really wanting to highlight that here and thinking about the context of individuals who may go without substances for a time and then resume use. We need to be thoughtful as providers and as professionals of those challenges. So moving on, we'll think too about, again, as always, in our organization and certainly other models as well, we believe firmly in providing co-occurring treatment and care services, because we know that these issues, whether it's substance use or mental health issues or medical issues, those physical mental health substance use issues, that they don't exist in silos, right? And so they all are very interconnected, and the interplay in this case, especially between mental health and substance use issues, is so pertinent. And we see that during this time of, we've talked a lot here in this section about isolation, but also just people who are under tremendous stress, pressure, hardship. They could have a loved one who's been directly affected, or they themselves have, could have acquired COVID, or they've lost their job due to struggles within the economy and different markets. That stress can increase anxiety, depression. It can be very triggering to maybe past trauma or other issues that have taken place. And, frankly, even the current trauma of living during this tumultuous time, and then how that plays into either triggering relapse or maybe even first time use. So something that we think about there. There's been a lot of research. I've included different references in our articles list, looking at different work that's been done, long before COVID, and thinking about natural disasters, war, how those really trying times can affect individuals across different levels of society, socioeconomic status, background, and that the key is that really no one is immune in many ways to the effects that a time of hardship like this can have. And so, I've highlighted here too a New York Times article that came out, and it talked a lot about how, well, a number of things. A Kaiser Family Foundation study looked recently and found that roughly 50% of all Americans note that they have been negatively impacted by COVID, specifically regarding their mental health. I mean, while that is a significant number, it's, arguably even, an understatement, or kind of is maybe on the low end, because while certainly the stress and the impact affects people in different ways, certainly, it would be hard to imagine finding someone in this country, or, any country in the world, that hasn't been, negatively impacted by the pandemic. And so I also bring this up too, because while there is so much that's going on that is very difficult, this also is a time for opportunity, for growth, for resilience. And really, when we think about the core principles of the treatment strategies and approaches that we use in treating co-occurring mental health substance use disorders, in many ways, at the core, what we're trying to do is certainly create awareness and reduce that ambivalence, but also to build resilience and to build adaptability in order to be able to cope with challenges. And so I think this is an interesting article as well, because it sort of highlights not only issues with resilience, but thinking about, they talk about tragic optimism here, and the ability for an individual to maintain hope and find meaning in life despite, pain, loss, suffering, especially that we see in war, natural disasters, pandemics, right? And so being able to see the good, and being able to see that even with challenges come those opportunities for change. And so, I think more than anything else, what we always aim to do is to empower individuals and families that we work with who may be struggling, thinking about strengths, thinking about goals and values and ways that we can help individuals to really remain true to those goals and values, even with obstacles. And while this at times can be a big obstacle, this is still an obstacle, this pandemic that we're living in, that we can help our patients and that we all can overcome. And so that's definitely a message that we always want to send, is one of resilience and positivity and opportunity. So transitioning a little bit, we're going to move on now and think about how substance use and stress go together, but not only how one can lead to the other, but how they're very similar in many ways from a physiologic perspective. And so, we know this overall is a graphic that highlights the role of stress on the body and sort of how those signaling pathways are created, and how the cascade effects of stress and hormone imbalance and dysregulation can affect our bodies. So too do we see that the strain and stress that comes from substance use not only creates a very similar process and pathway throughout different systems in our body, but also thinking about withdrawal, right? And so what that does. And so just as an overview, we know that the HPA, or the hypothalamic pituitary adrenal axis, is very much involved with stress and anxiety, and that these same pathways are affected by substance use and withdrawal. And so that we know, kind of to give a rundown, that the stress hormone, or under stress, that the brain releases corticotropin releasing factor, CRF, into the bloodstream, which then signals downstream different stress factors that come into play. And ultimately, our immune systems are involved, our endocrine systems are involved, and with one of the primary output points being the adrenal glands, the kidneys. And that's, the adrenal glands produce adrenaline or epinephrine, right? And so that's that jolt that you may experience when there is a traumatic event or issue that comes up, or a spike of anxiety, that kind of instant with heart racing and maybe sweating, cramping stomach, things like that. This pathway is affected by stress of everyday life in a pandemic, but also the stress that, as I've mentioned, that substance use plays onto our bodies. So just wanting to highlight that, and that not only do they, again, affect one another, stress and substance use, on our bodies and physiologically, but that those pathways are very intertwined and interconnected. So we'll move on and think about the cost of substance use. And I thought this was an interesting article that came from the UN recently, looking at the variety of different impacts, right, that substance, or that COVID has had on the world. And what we're seeing in particular, and we'll be talking about this, today and in our future session too, thinking about, oftentimes with, the opioid epidemic that we're still in, long before this pandemic and an epidemic and issues related to COVID, we were already in an epidemic when it came to opioids. And actually what we're seeing is that, to highlight from this article, they state that drug shortages are increasing the number of IV users who are also sharing injection equipment, right? Because supplies are shorter at times depending on different types of substance. And so with that also comes increased risk for other public health issues and concerns relating to HIV and AIDS, hepatitis C, as well as the potential transmission of COVID itself. And so certainly food for thought there, that there are certainly many downstream ripple effects that are affecting people in many different ways from public health perspective and substance use. Also, I've included data highlighting here from the NIH looking at the cost. These are data and figures related to the US. And overall what we see, and this, these are recent data from 2018, that in the US, the estimate is that annually substance abuse and use costs over $600 billion when we think about the direct impact and effect of individuals who are struggling with use, the impact that has on communities and families. Also, the medical complications, morbidity, mortality associated with substance use, lost days of productivity at work, and just lost opportunities for individuals and families to be together. And so while that's a staggering dollar amount, I think that, even more important is, again, those incalculable impacts on families, communities, and individuals with just lost time to be able to spend together, to enjoy time together, those lost opportunities in life is, certainly one of the many reasons why, we at Rogers, and, I imagine many people in this field do this work, is to help people to get back to living. And, especially with substance use and this pandemic, many times people are just trying to survive. And, it can be a slow process, but really, I think it's so important to help individuals to keep their eye on the prize, so to speak, and with those goals and values, and thinking about how we can help them to get out of this phase where they're surviving, and helping them to get back to thriving. Yeah. So, and lastly, I'll say here, what's really interesting is that they noted in this UN article going back that, different types of substances are typically produced, manufactured, distributed in different ways. And so they looked especially at methamphetamine, cocaine, heroin, cannabis, production and distribution, and that, these substances and their production distribution has really been disrupted and trafficking throughout the world because of COVID and lockdown, and the way that borders have been affected throughout the world. And so methamphetamine typically comes out of Asia, not exclusively, but many times does. And so a lot of air travel, because of its impact and decreased air travel, that's certainly affected methamphetamine, distribution, whereas cocaine comes from a variety of different places throughout the world and is oftentimes transported via sea. And so there have been certainly some disruptions there that we've seen. Heroin oftentimes is moved over land, but we're seeing that with different disruptions that there has been more of a push towards maritime distribution and trafficking, whereas cannabis is typically produced and distributed more locally. And so there have been some impacts, but maybe not as much there. So now we're going to move into a section of thinking about how we can engage youth. And we will talk about, I know that time is of the essence, so I'm going to move a little bit more quickly, but wanted to just actually start by highlighting, a common site, certainly not trying to advertise for StreetRx, but just to, make people aware, if they weren't already, about, sites, apps that exist that, make it easier than ever to be able to look up prices and even distribution. So certainly not promoting that, but thinking about making sure that we in this field as providers and trying to help individuals struggling with substance use, that we're aware of these different resources that those individuals struggling with substance use are oftentimes tapping into in order to be able to research, and acquire substances. So going into the next slide, then we think about how, engaging youth is always important, and it is now more than ever. And in this, technical world that we've been living in, and in this virtual world that we're living in ever more now in COVID, we want to really think about ways that youth communicate and interact with one another and with the world. And now is the time more than ever to be able to educate ourselves and to be able to be familiar and up to date, up to speed on, different apps that youth use in order to communicate. Social media is huge. That's not going anywhere anytime soon, I don't think. And so thinking about, different ways that youth are engaging one another, that they're researching in this time of isolation, and then also being able to utilize these technologies as means to improve our ability to help individuals recover, right? And so we'll be talking, I know Dr. Maloney is going to talk some possibly today and then definitely in the future about, recovery support and technology. And so being able to utilize apps. Contingency management, is another approach that now more than ever, when we try to work to create engagement in thinking about how we can create positive reinforcement for individuals who are engaging in those pro-socials and who are engaging in treatment and care. You know, while we can get burned out with technology, again, I think about the opportunities that we have today versus what we had even 5 or 10 years ago, and certainly, you know, 50 years ago, that we can check in with individuals, and that the ease of access to one another, certainly we want to, you know, maintain those appropriate limits and boundaries, no doubt, but especially when it comes to appropriate engagement and trying to reach out and engage our youth, any individual during this time of isolation. You know, we have, you know, FaceTime, Zoom, a variety of different video conference utilities that we can utilize in addition to phones that we've had, and being able to text to check in is really, really important. And we definitely encourage the use of those appropriate technologies to be able to engage individuals struggling. And especially with youth, we've known this, but, you know, now more than ever too, just knowing the lingo when it comes to, you know, pop culture, social media, and substances, and being able to know about different sites and apps is going to be really important, because I think that whenever we can, you know, show that we care and show that we too are engaged in what's going on in their world, that, you know, many, many times will help to create engagement and further buy-in, so that then we can use that to create an opportunity for change and education and to build insight. So, you know, on the next slide, we'll see that, you know, there are a variety of different resources that are free to the public that we can use to engage our youth. And so, you know, looking at these, and these are just some of the resources out there that really, you know, we want to always start with education and prevention. And we know that when we're talking about youth in particular, it typically, in my experience, has not been as effective oftentimes to, you know, we want to be able to engage and we want to have a discussion, and we want to always try to avoid, whenever possible, lecturing, right, or kind of talking down to youth, because they're sort of expecting that we're not going to engage them one-on-one in kind of holding them accountable, but also as an equal in many ways. And so, you know, whenever it's possible, therapeutically, appropriately, to be able to engage them in a way to let them know that we see it, they're sophisticated, that they are intelligent, that they, you know, that they're aware of different things. And I think that what's really nice about some of these resources that I've highlighted here is that they certainly provide education and engagement in a way that is appealing to youth, and really, more than anything else, instead of trying to tell them that they shouldn't do something, provides, you know, really aim to provide more just awareness in order to help youth to be able to make informed and safe decisions. So moving on, we'll look at drug screening, certainly an important topic here. What I'll say is, you know, definitely during this time of COVID, there have been a variety of different challenges that have come into play, and that oftentimes, you know, we'll talk here in a future slide about ASAM releasing a statement a few months ago, the American Society of Addiction Medicine, that, you know, in many cases, it's not really possible or always appropriate or always the safest to be able to provide traditional in-person urine drug screening. And so when that's, you know, the case, how do we look to other avenues, resources to be able to still utilize drug screen testing, but in a way that is in keeping with social distancing and the challenges of these times. So just a few things here to highlight, just that really the way that we you know, often approach drug screening is really, it is an opportunity to be able to recognize individuals' hard work, and that our goal in this work is not to police individuals. It's not to, you know, catch them in the act per se, that does come up, but rather also to look at ways that we can more objectively also highlight, especially, you know, individuals when they have been working hard, when they've been reducing their use and ideally abstaining from use. And so that's really the aim of what we're looking to do here. And certainly we know that while it is not ideal, that relapse is a part of recovery. And so that's certainly not, you know, giving in or saying that we want individuals to relapse, but also, like Dr. Jones highlighted earlier, that, you know, this is a neurobiologically based illness. And if we liken it in many ways to the struggles that people can have with, you know, diabetes or obesity or, you know, other public health concerns, rarely, if ever in those cases either, do individuals, have success the first time out. And so the more that we can support and encourage and approach this work with compassion and being objective and helping people, individuals to be accountable to themselves and to their substance use issues, but also to help them to keep going when frankly, it can be really difficult for them to keep going at times when they feel like no matter how hard they try, they still struggle. So moving on, we'll think about urine drug screen testing, like we talked about, is oftentimes preferred and has been many times the standard, but looking at being able to provide urine drug screen testing in ways that is in keeping with social distancing and isolation, but also what we have done too, moving on to the next slide, is looking at salivary testing. And this is something that has been around, and really, I think what's really nice about this, and we provide these services, is to be able to provide point of care instant salivary drug screen testing, and it can be done in a way that the test kits are delivered to a patient's home, and they are sealed and secured. And what we ask is that individuals are going to keep those screens sealed. They open them on camera with our nurses. They go through and do the testing, which the instant testing only takes just a couple minutes, and right there on screen we can see the results. And so this is a really nice way to be able to still incorporate testing services, but in a way that also is mindful of social distancing. And so we use our own sort of platform to be able to provide this, but in essence here, just the picture being that like really you could be anywhere, ideally in a confidential, clearly like safe space, right? But that through telehealth technology, many limitations and barriers to doing testing and other types of treatment, like we've talked about, are in many ways reduced, and that these again are opportunities. So moving on, lastly, just looking at what we've already highlighted, that even with salivary testing, that no test is 100% reliable or accurate, and that clinical judgment really, as always, comes into play, but that this is certainly a resource that can and should be utilized, and that not only different testing methods, but especially telehealth services, as we become more sophisticated and adapt existing known foundational framework for evidence-based treatment and care, and as we are adapting that into this virtual telehealth world, I think it's also pretty exciting what we've already been able to accomplish, and hopefully where things will go in our field. So with that, I'll turn it over to Dr. Jones, I believe, who is going to pick us back up and talk about assessment.
Thank you, Dr. LeNoue. So we're going to transition into assessment of patient needs and risk factors. We're going to talk a little bit about support for vulnerable populations, but I have a very extensive presentation for that next week to go into more detail. We'll talk about increased access to substances and the development of new or worsening mental health and addiction-related issues due to stressors associated with the pandemic. So, support for vulnerable populations. Telehealth risk assessment is something that you'll want to do with vulnerable populations. We, as I've mentioned, have an increased risk of intoxication and need for detox. There may be a lack of resources available to provide the drug test or screen due to transportation issues, funds, internet access. And what we can do in these situations is really what I want to highlight, is that you can see what your agency has to offer regarding financial support if you work for an agency. Try your best to be flexible with the patient using the phone instead of the computer, if that will help. Identify an emergency contact and identify if others are in the home to assist if needed right away on intake. This also includes identifying where the closest emergency room is for them in the event that you do need to have them transported to the hospital. With regard to the COVID-19 pandemic, there's been a significant increase in access to substances. And Dr. Maloney mentioned that a lot of distilleries have transitioned to putting hand sanitizer in their alcohol bottles, in their alcohol labeled bottles. And so it's really important to recognize that shift in culture that has occurred, which is potentially increasing access to substances. There are deliverable alcohol resources from restaurants in some states. I know California, most of the restaurants that do serve alcohol are providing alcohol for you that can be delivered directly to your home. If they're not providing alcohol, they're providing ingredients to make signature cocktails, and it is already in it, the cost is lumped in with what you're eating. So if you order a meal, it comes with a margarita or a pitcher or something of that nature. Companies like Ease or Drizzly, they conduct home deliveries of alcohol and or cannabis. So it's just a lot easier for people to get substances than it was prior, because alcohol delivery was not allowed. But with the closing down of businesses and the shelter-in-place order, that regulation has been lifted in a lot of places. Buying alcohol from the store, patients and clients are at higher risk of buying in bulk and having access to their substance at home all day, every day. If there are a lot of places that run discounts on alcohol and substances. And so it just increases the likelihood that the substance is easily accessible, readily accessible. So something to take into consideration. And there are fewer options for activities. So ease of access coupled with fewer options for activities like playing sports and attending events increases the likelihood of use due to boredom. And that is across the board one of the biggest reasons people say that they use substances. And then we have the development of newer worsening symptoms due to stressors associated with the pandemic. So depression, home isolation, inability to socialize with others tends to increase depressive symptoms. And then you have an increase in alcohol use, which then increases the depressive symptoms. And the patient or client engages in this cyclical pattern that develops of the depression and the substance use. There's a lot of anxiety around fears of getting COVID, and that it may increase substance use to reduce those anxiety symptoms as well. With regard to substance use disorders, we are bumping up against an increased risk of comorbidities. So increase in substance use to manage other mental health symptoms, which then can promote or facilitate the development of a mild or moderate substance use disorder. So maybe someone who maybe only drank socially is now drinking daily because they quote unquote don't have anything else to do, or they're using it to manage their depression because they're not able to go outside or they're not able to do or engage in their regular activities. And there are minimal ways to engage with others. So our society has already developed a new virtual culture of virtual happy hours. And the intention is to promote connection, but it also increases the risk for those who have substance use disorders because they ended up having this virtual happy hour and everybody's asking where their drink is or where their beverage is. And so there's pressure that can be placed on patients who have substance use disorders. There's also difficulty working through technology to participate in community meetings. So a way to kind of mitigate this is a clinician can provide resources to patients regarding those virtual community meetings and assist patients in working through their technology to connect with other sober groups. So that may be something that we didn't do before COVID and before the shelter-in-place orders. We would give them a list of community meetings that they could go to, and that was it. And now we can actually, again, share our screen and maybe walk patients through how to actually get to a virtual community meeting. So we can be resourceful in that capacity. So the 5 key take-home points are that we want to make sure that we are supporting our vulnerable populations, that we are increasing, or that increased access to substances with challenges in the detection is an issue. The development of new or worsening mental health and addiction related issues can be due to the stressors associated with this pandemic, and the challenges can actually serve as opportunities for change. And telehealth technologies can be and are the future of some of the treatment that we're doing.
Thank you, everyone. It is now time for the Q&A portion. If you have questions, please use the Q&A button, not the chat feature on the Zoom taskbar. Since we're running short on time, we will not be able to answer all of the questions, but we will try to get through a few. The first one is a comment from one of our participants. Please check in with the presenters, how they personally are doing with the current events regarding the killings and demonstrations.
This is Dr. Jones, and I appreciate the person who asked that question. I think that it is an important question, and I don't want anyone to think that this presentation was done without consideration of the killings of African Americans. It has been, for me personally, extremely exhausting and challenging to even put a presentation together in these times. And it is difficult to work emotionally, but I think that this is an opportunity for shift and change, not only in our culture, but in our country. And I'm grateful that there are people who are wanting the same change that I have wanted for my entire life and that my family and history has wanted. So I appreciate the person asking that question. And from my stance as an African American woman, I can say that I am struggling, but I'm grateful.
Thank you so much, Dr. Jones. The next question is, what has been your biggest challenge so far doing telehealth, and how have you made adjustments?
I could take that, and I can start us off from our team in that. So this is LeNoue, and I've actually been doing telehealth for multiple years now prior to COVID, but to now really move into a platform that is almost, completely telehealth has certainly been challenging in some ways. I also think that we're really fortunate at Rogers to be able to have a really great leadership team and administration, and frankly, just really great people who are really passionate about this work to be able to serve patients and families. And so it has been challenging, no doubt, in trying to kind of figure out, like, how do we make this work in a virtual world? Most importantly, in our duty to patients and families, to be able to provide them quality and evidence-based care and services in a meaningful way, right? Because this work is so much more than just following guidelines or protocols. Those things are very important, no doubt. But really, a lot of the work that we do here, and I think that everyone in doing this work does, it's that human connection. And so being able to find ways to create connection is so important now more than ever. I just would want to say, just briefly back to the previous question and comment, just that I definitely would echo the thoughts and sentiments of Dr. Jones, and that certainly it is a tragedy. What has happened with the killing of any individual, and that what I hope for now more than ever is just that we are able to come together as a country, as a people, and to be able to really unite and see that differences are good things, and that's what really makes people and culture rich and wonderful, and that but also that there's so much that is really so similar in a really wonderful way that we as people, I hope that we can come together even more, and that, here too with mental health and substance treatment, that's something that comes up in our clinic and work all the time. And so again, I do hope that this is an opportunity for change and good things that can come.
And Michelle, what I would add to that, this is Michelle Maloney. As we've been embracing telehealth and our treatment has been telehealth, we've also experienced some unexpected challenges, or at least for me, what was it? Unexpected challenges, truly getting an insight into family dynamics, as Dr. Jones mentioned at the beginning of the presentation. We've seen anywhere from, families that have been struggling with their own substance use that weren't the identified patient to, other individuals having sexual relations while a patient is trying to receive telehealth therapy. And so I think it is, something we've just tried to embrace and really try to roll with it. And I think one of the things that's brought about for our treatment team is just the ability to connect more as we continue to treat patients during these challenging times, as we continue to go through these challenging times.
Thank you again. I am so honored to work with this team, Drs. Jones, LeNoue, and Maloney. Thank you for taking time away from your clinical practice to share your valuable insights with us. Next week, Thursday, June 18th, we will offer the second webinar of the series, Treating Mental Health and Addiction During COVID-19. Today's presenters will be back and will highlight some of the necessary cultural considerations and community factors. I know we didn't get to all of the questions, but we have collected them, and you can also send me an email so we can try to get to those important questions. I'd also like to let you know that Rogers is here for those who are struggling with mental health or addiction, now potentially more than ever. We continue accepting patients in both inpatient and residential settings in Wisconsin, and we are very proud to offer Rogers Connect Care, our virtual option for those needing intensive outpatient levels of care. Based on recent decisions made in several states, we are starting to transition some of our partial and intensive outpatient care back to the clinics using a hybrid model of on-site and virtual treatment. While these patients will be physically in the clinic, they will continue to use the same virtual treatment via Microsoft Teams while on site. And before we conclude, I'd like to ask our presenters to share their recommendations on additional resources for our participants.
Yeah, I would just say these are all wonderful resources to start with, and certainly these are not the only resources during this time or others, but these typically are go-to resources that provide really quality evidence-based options.
And to add, NIDA would be helpful as well, a good resource to go to.
Thank you. That about wraps it up, everyone. I will remind our participants that those of you who meet the required time commitment will be eligible for CE credits. About 30 minutes after the webinar ends, you will receive an email with a link to a mandatory evaluation form. Once you complete it, you may download your CE certificate for the event. We will have a recording of today's webinar and a PDF of slides available on our website, rogersbh.org. On behalf of everyone at Rogers, we look forward to partnering with you to help support your patients. Thank you.
Thanks, everyone.